What up, Z-Pack? It's your boy ZMommMD. Check it out. I am live at the Z-Dog Ancestral Family Home in Clovis, California, where I'm visiting the Z parents on the way to the Bay Area, where we're doing a little radical sabbatical. But anyways, that is not going to stop us from doing Incident Report Live pretty much every day, because it's what we do. This is the mobile edition. Tom and Logan are busy at work back at Z Studios in Las Vegas, setting up an insanely awesome studio experience for when we have guests when I come back in a few weeks. It's going to be dope, so prepare yourself for basically Incident Report 2.0 and wait till you see 3.0 because it's going to blow your mind. Anyways, hi Autumn Braun, how are you? Hi Karen Palmer, welcome back. So I'm in my dad's like old school office here, and I wanted to talk about this Tufts nurses strike that's going on. It's making national news. 1,200 nurses walked away for a day as part of a union dispute with management at Tufts Medical Center in Boston. The biggest nursing strike in Massachusetts history, and worth talking about, and I'll tell you why, because it really highlights how far we have to go yet to get to Health 3.0, where we are all collaborating in service for each other and our patients. It's still an adversarial thing, and it's still administrators versus nurses versus doctors versus patients sometimes. And this is what I want to talk about today. Now, I usually never, ever wade into union disputes, and I'm going to continue that in the sense that I don't take sides in this. I'm not there on the ground. I don't work in the organization. It would be really irresponsible for someone like me to come in and go, yay nurses or yay administration, because I'm not there and I'm not on the ground. And so a lot of people message me about union disputes around the country, and I generally don't get boots on the ground involved. Now, in this case, I want to talk on a high level, and I want to kind of go through the story. And I'm pulling up a WBUR public radio or public NPR type station in Boston that I respect a lot, that I tend to follow their articles. And it's a pretty good balanced article. I'm going to just kind of go through it. We're going to talk about the big issues. But first, hi Desiree Gold. First, I want to show you this funky office that my dad has worked in since 1980. It's not his practice, it's his sort of home office. So you guys are going to dig this. My dad's wandering around, by the way, Z-Dad, and Z-Mom is taking care of the two kids, and Z-Wife is actually doing a Skype violin lesson for the youngest Z-Pup with their teacher back in Las Vegas, because the tiger momming doesn't end. It doesn't matter if we're traveling, there's still tiger momming. So I'm going to take you on a quick tour, then we're going to talk about the nurses' strike, and we're going to go through this article. Okay, check this out. Okay, he's got a legitimate barometer, all right, and a really, really cheesy little exercise thing, because he's in his late 70s and's got to get his exercise on, because that's what anybody who cares about nutrition does. The iRobot, that's right, because you got to get your vacuum on for little to no work. Then a really tacky 80s era little piece of sculpture. This looks like it came out of a medical office. I'm not gonna lie to you. All right, that's my dad's taste. Then you've got this thing, which looks like it also came out of a medical office. Now going over here though, look at this. So I don't even know what this is, but I'm scared of it. And then you've got this, a picture from, we had two weddings, Mrs. Dog and me. We had a traditional Western wedding, and then we had a Zoroastrian wedding, where we got dressed up and the Zoroastrian priest did a bunch of chanting. Now you guys got to understand, I'm an agnostic, so this was very uncomfortable for me, but culturally very important to my parents. Z-Dad and Z-Mom dressed in traditional gear. So I thought I'd share that with you. If you guys were wondering about my brother, here he is. He had basically gotten in really good shape by the time he graduated high school, but when he was young, I had mentioned that he was a bit on the chubby side, and it just goes to show, there's our little family picture. Look at Z-Dad. My sister, my brother, and me. It just shows you can get in shape even if you struggle with childhood obesity. You never give up and you do your thing. By the way, here's Z-Dad with the eldest Z-Pup when she was just born. Isn't that cute? With an ancient silver rattle that was passed down from his family by generations. So anyways, here I am with my sister, by the way. Look at that. Talk about childhood obesity. Look at that. Anyways, here we go. Back to the lecture at hand. And as we've been talking about, we like to run a quick 15-second Facebook ad break so that we can help pay for all the renovations and expansion we're doing in the studio and for Tom and Logan's diapers. Tom wears adult diapers, Logan has a child. So stick with me for 15 seconds. We're going to come back and talk about the Tufts Medical Center strike. Here we go. I'm going to pull up this article so we're ready to go when we get back. All right, guys, bear with me. Okay, guys, let's talk about this. So there are so many issues that come up when anybody in the medical profession goes on strike, and nurses get the big press because they're the biggest group and arguably some of the most aggrieved when it comes to management and employee disputes. And increasingly in the world of Health 2.0, where we're all in these sort of business operations, these big consolidated business, whether they're integrated hospital groups or big integrated health systems, it becomes an issue of you have different layers. So you have administration, and then you have the employees, the frontline healthcare workers, and you have the doctors, and you have the other staff. And increasingly it becomes a commodification issue in 2.0, where we're all these sort of assembly line cogs trying to make this big machine of standardized medicine hum along. When you have that, of course, you're going to have these sort of labor disputes because we're not necessarily going to be all aligned around a particular mission. A lot of times there are these little balkanizations or fractionizations off where the nurses have one agenda, the doctors have one agenda, the management has another agenda. And the tricky part is they don't really walk in each other's shoes usually, and as a result there's a lot of misunderstanding. When it comes to nursing in particular, it gets very, very difficult. So these Tufts nurses are unionized. And in their first nurses' strike in Boston in 30 years, they walked out giving, and Jennifer Lombardi's story gives a good point because someone was raising the issues of abandonment. Are you abandoning your patients? Abandoning, and in healthcare when you go on strike, it's a big deal because again, people's lives depend on you taking care of them. They gave apparently a 10-day warning that they were going to strike, and they continued negotiations into the last night. And replacement nurses were already in place. So the management at Tufts, the CEO, had contracted for 5 days of what I assume are travel nurses or contract nurses to replace the nurses who are striking. And even though they were only striking for a day, they're effectively locked out for 5 days because of the contract with the new nurses. So this is the sort of logistics as I understand it, and I want you to correct me if I'm wrong because again, I don't want to misrepresent what's going on. So in the setting of that, and I'm going to scroll down to the bottom of the comments here so I can kind of incorporate them as we're talking. Susan Young already points out, how about the organization abandoning their nurses? Now this is, again, this is the give and take between the two sides in this, and this is why I won't take sides. I'm going to try to present all sides here. So if you think I'm going to come up and be like, yay, whoever, you probably want to tune out, but we will talk about both sides. So basically, the nurses, from my understanding from the press, and you guys can message me if I'm wrong, there are sort of three issues. There's wages, which are at Tufts Hospital the lowest in, what seem to be the lowest in town. So Brigham, Mass General, et cetera, have higher wages, whereas Tufts has lower wages. The explanation that and it's considered by, according to the article, a place where entry sort of nurses new out of training come, they work for a couple of years, then they leave because the wages are higher in the other hospitals that maybe require more experience. Now Tufts argues back and says, look, we get reimbursed the least, we have a higher Medicaid population, and so it's very hard for us to be on par with the wages of these other organizations. So that's the sort of management's side of the equation. Now the second issue apart from wages is staffing. So the nurses are saying, they're understaffed. Now this is something that's very sensitive to the Z-Pack and to myself, because if you are truly understaffed, it is very, very hard to provide compassionate quality care in a very 3.0 way if you don't have the time to spend with the patient to understand their unique issues and to actually manage the logistics of care, particularly nursing care, but also anybody. So physicians, when I had 30 patients, I can't do a good job. When I have 15 patients, I can do a tremendous job with those 15 patients, assuming I'm a compassionate, dedicated caregiver, in which case I'll spend that time I would have spent with those 30 with those 15, and that's how I used to practice. Now, granted, not everybody does that. Some people will slack to the degree that they aren't pushed, but in general, I like to give people the benefit of the doubt. So the third piece of this strike, from what I understand, is pensions. So there are about 300 and some odd nurses who are still on an old pension system where they get a guaranteed payment in retirement. Now, Tufts is pushing back, as are many organizations, saying this is no longer a sustainable thing. It's very hard to generate the kind of returns to actually guarantee a pension. Now, I don't know the details of this, whether the nurses had been paying in and had been grandfathered in, or what the deal is, whether it's an abandonment issue to say, no, we want to switch you now to a defined contribution plan, which is, I presume, less expensive for the organization, involves investing, and a little different structure than a guaranteed payout plan. It's more like an investment, like a 401k with an investment plan, and the Tufts will give you money to then put in these plans. And that's what I'm using myself, but I'm self-employed and I have to do that. So there's no pension for me. I have to make sure to manage my assets appropriately. So again, first world problems, but real problems. So that's the third issue in this piece. Now let's read some comments and then we're gonna go back. Melissa Turek says that's true. It's a 5-day lockout. Right. So the replacement nurses are working for a 5-day contract. Otherwise, I think Tufts was saying it's hard to get nurses to come in just for a day. Now remember, these guys got to learn the situation. They got to pick up all the new patients. They got to do everything. I mean, all the old patients and the new patients. It's hard to do. And I know I was at Stanford when we had a big nursing strike from Corona, I think was our nursing union then. And it was a logistical thing. Like overnight, there was plenty of warning, but then you got to get the new nurses in. And I've gone on record and said it was an interesting culture shift when the new nurses came in, because they were very non-academically minded. So they treated all the doctors, including the interns and residents, like they were community attendings, which they got used to real fast. Meaning the house staff, because suddenly they're like, oh my gosh, we get treated like doctors instead of like interns and punching bags for the nurses, which is how it typically is at a lot of academic institutions. That's part of the culture, right? So it was an interesting scenario at that time, and there were arguments on both sides, like, well, is it unsafe for patients? Was it safe? Did it work out? And in the end, they came to an agreement, and the nurses came back. So this speaks to me, again, this whole thing speaks to me about what's going on in our culture where we even need unionization in a healthcare setting. It means that we are not really anything close to 3.0. In 3.0, we all collaborate, we all practice at the top of our game in service of the patients, but we also support each other, and there's a bigger picture view that we're generating good outcomes, and we get paid based on good outcomes. Whenever you get paid based on good outcomes, everyone's going to work together to make sure that we optimize our human resources so that those outcomes are good. In this situation, it's actually a question of the 2.0 hospital organizations have to control costs and maximize revenue. And in a 2.0 scenario, that means high volumes of patients and low human resources costs. So of course they're going to say, well, the pension's too expensive. Of course they're going to say, well, let's try to have as few nurses for as many patients as is safely possible. And how are they judging safety, right? So it becomes this constant arms race to try to lower costs. This is why many nurses around the country, many doctors around the country say in a 2.0 system they feel like commodities. They're told they're replaceable, they're expendable. This isn't acceptable. At the same time, we have to understand where our 2.0 administrators have to come from. They have to come from this place. Otherwise, they're abandoning a fiduciary responsibility. Now, you could argue they're short-sighted. You could say that, well, no, in the long run, this is going to hurt patients. It's going to increase costs. It's going to lead to turnover, like what's happening at Tufts, where the nurses are leaving after a couple of years because they're not getting a wage that's concordant with the rest of the situation there. So it becomes a very difficult, nuanced discussion. What I want you guys to do, ZPAC, is instead of knee-jerking on one side or the other, I want to try to say, well, okay, can we look at this? Can we really look at this from all sides? Understand it's complicated and nuanced. Know where our own elephant lies, like our own intuition or emotion lies on X or Y side, right? Like, I mean, my intuitive emotional side is always going to side with the nurses because they're frontline healthcare providers that I resonate with deeply, and I want to support them in any way I can. But I have to try to take a more nuanced look at this for the sake of building a 3.0 world. Because if you take one side or another in this, you're never going to get to 3.0, because part of 3.0 is coming up with sustainable, scalable structures that finance the actual delivery of good outcomes. Look at Turntable Health. We had a 3.0 delivery system. We had health coaches, nurses, doctors, social workers working together in a team with our patients, empowering them. We had tremendous, what we used for patient satisfaction was Net Promoter Score. How likely are you to recommend this clinic to family and friends? The scores were off the chain compared to any other healthcare sort of organization at scale. But We were expensive. It was hard to find payers in town in a 2.0 system where it's volume-based to support outcomes-based pay when the government doesn't even pay for outcomes. So there was no financial structure in place. So when you're building it, as an administrator, I was an administrator and a practitioner. As an administrator, it was very hard to see how do we grow this. So you have to look at all of it. We need systems change. We need to be paid based on outcomes. We need to reward organizations for taking care of their employees. So in a 3.0 world, you would never get to a strike point because before that, the organization would be hemorrhaging cash because you'd be penalized for having unhappy employees or unhappy team, right? I don't even like the term employees because really we're part of an integrated team that's taking care of the patients. Let's read some comments here. Okay, let's see. Let's keep going. Indentured servitude, says Kathleen Cowell. Emergency physicians mandated under EMTALA to see all patients without any federal remuneration. Right, Kathleen? So again, we're not getting paid on outcomes. We're trying to bandage a broken system where people don't have coverage, where they're uninsured and indigent patients, and then we're forced to see them. Now, people argue that healthcare isn't a right because a right doesn't infringe on others' rights. Well, already we're infringing on others' rights by asking physicians to see patients without reimbursement. It's very, very difficult. So we need to actually figure out bigger structures that are going to cover that over time without bankrupting the country or turning us into 1984. Orwell's 84, not the actual year 84. Utah nurses, says Lester Steed, get paid 37% less than the national average, partly because there's no nursing union. So unionization will, arguably might raise wages. The question is, I would love a world where we transcend the need for unions. We are not in that world yet. In a 2.0 world, it's still an adversarial relationship, but I do want to stress that it is very tough for hospital administrators to actually survive in 2.0 without doing this kind of nonsense. So don't we need 3.0? Isn't that the answer to solving this problem? It is. What do we have here? Michelle Arroyo, I got the 1984 reference. I'm amused you had to explain what you meant. It's a brave new world. Aldous Huxley. Erica Bailey, Utah nurses get paid less because there's no one major employer, no competition. Or maybe there is one major employer, is what Erica means. And again, I don't know about the situation in Utah. All right, so that being said, let me go through this article a little bit. So Tufts is replacing, using 320 replacement nurses working 12-hour shifts to maintain normal operations. So that's one of the logistics of this. And they were saying they're still seeing the same number of patients, if not more. We have 60 cases booked in the OR. Every organization above capacity in Boston, treating more than its normal volume of patients on Wednesday. So this is management pushing back and saying, we're seeing the patients. Their state representative, Marjorie Decker, and some state politicians joined in with the picketers, and were lashing out at hospital administrators. How dare you put your patients at risk? If you're medevacing babies there, if you're doing heart transplants today, you're putting your patients at risk. Now I'm going to say something here, and again, I support nurses. This is an irresponsible statement. I think what we need to understand from our politicians is why the hell aren't the politicians actually making it so that we actually have a good healthcare policy locally and nationally? They wait for shit to break down and fall apart, then they come out and support one side or the other. It doesn't matter which side. If you're a Democrat, you support the union. If you're a Republican, you support administration. It's just stupid. Can't we actually figure out what is going on more globally and get our politicians on board with actual, real, meaningful solutions instead of picking a political side and then just piling on? And I don't care what side it is. This is just typical. This is politics as usual. It doesn't matter what side. Because there's going to be another politician who's going to come out and go, we support the management and these nurses are creating a dangerous situation. So it doesn't matter. It's just more of the same crap. Let me keep going through this article and getting angry. So now Wagner, the CEO, acknowledged that hospital leaders were feeling some heat. Is he the CEO? Let me make sure that's right, or if I'm getting that wrong. Yeah, Dr. Michael Wagner is the CEO, so he's a physician. All right, so at least we have medical leadership, right? Because sometimes it isn't the case. where was what he was saying? How did I lose this? Oh, here it is. There is appropriate level of concern being raised by politicians, but I think they also understand very well the great challenges we face, the reductions in reimbursement and the uncertainty at the federal level. So what Dr. Wagner is arguing is that the federal government is in chaos about healthcare. We have no idea what's going on. Reimbursements have been declining, and this is now what you get, is what I think I'm interpreting this as. So again, is that correct or not? The truth is, this is what he sees as reality on the ground. Let's read some more comments here, because I want to hear from nurses in particular about what's going on here. We need more change makers in medicine. I'm sick and tired of the reactive approach to healthcare. Dondi Hardwicker. Listen, stay tuned, guys, because cool stuff is happening. Stay tuned. We'll have announcements later in the summer. Wait, a CEO is a doctor? Ours is a lawyer. We're in trouble. Veronica St. Dennis. So the data seems to show that clinician leaders, let's be more broad, have better outcomes at organizations than non-clinician leaders. Sorry, non-clinician leaders. Some of you are great, but I'm going to say that intuitively feels right to my elephant, and the data seems to support that. Jane McCarthy says, "Wake up, everybody! The public has no clue what's really going on unless you're, on if you're a patient. Scary." And then Crystal Kreider says, "This didn't just happen. This has been brewing. Administrators continue to make cuts. They push unsafe ratios. It's all money-based. The nurses always take it in the ASS." So this is, I think, a universal truth that whoever is considered to be the bottom of the rung is going to take it, and that is going to be the nurses that felt the most pressure in Health 2.0 as the cost cuts and all this are happening. What I'm saying is there are two sides to why the cost cuts happen, but in the end, it is frontline clinicians who suffer, which means patients suffer. So we need to fix this. So that's really the bottom line. Now I'm going to go to a quick ad here to generate some money to pay for Logan's diapers, then we're going to come back and talk about solutions. Here we go. And stay with me. Tell me what you see as an ad, because it's still kind of fun to see what Facebook's targeting to you. All right. Now I want to hear from you guys. Thanks for sitting through that. I want to hear from you guys what some potential solutions are. Now I'll tell you some of my thoughts. First of all, if hospitals get paid based on actual outcomes, now this is where it's tricky because measuring outcomes is very hard, especially when you use surrogate markers. Like hypertension is not a problem in itself. It is a surrogate marker for stroke, heart disease, kidney failure, dementia, those kind of things. So how do you actually measure preventing a case of diabetes, for example? That's very hard to do. Doesn't mean we can't do it. It means we need to figure out the science behind actually doing that. Sometimes it's as simple as looking at a global, what are patients' wishes? That's part of it. So if you look at practicing good medicine, we ought to be rewarding people for good evidence-based medicine that also takes clinical experience into account. So like what we're seeing on the ground, and the patient goals. So what does the patient actually want to see out of their care? And I'm not talking about Dilaudid in a turkey sandwich. I'm talking about their goals, their hopes, dreams, and fears, right? If they're taking Dilaudid and they want a turkey sandwich, is their deeper goal to live in a world without chronic pain, or to live without depression and they're treating the depression with narcotics, or to have a job or some economic stability? And those are the things that we need to kind of look at in aggregate. And I think at some point we can get there even with artificial intelligence, but rewarding hospitals based on real outcomes means that part of that aggregate outcome is clinician satisfaction. It means nurses, doctors, pharmacists, respiratory therapists, speech pathologists, everybody on the team, optometrists. How are they feeling as part of this? And if they feel involved with a sense of purpose and a higher calling and connected and valued, then the organization gets paid more. And when you do that, you transcend the need for unions and things like that, because everybody's skin is in the game of making the most money possible by treating each other nice, by taking care of patients, and by having good science-based medicine. Now, we're not there yet, but that's the goal of a 3.0 payment structure. That may even be a 4.0 payment structure, right? Let's read some comments. I'm a nurse practitioner. I feel very respected, but I feel sad for nurses who are treated poorly, not as a professional. Brittany Kurtz, absolutely. Sheila Cooper, you guys have to understand it's about money on every side. Nonprofit and profits have to budget and stay in business to keep you getting a paycheck. I personally think a new model is needed, more team than patient, and then it gets cut off. So keep your comments short. If you want me to read them on air, I can read them later, but the way the phone works keeps them this short. I understand the financial concerns of the administrator, says Josephine Zeicher. This is why floors are filled with those less than 3 years of experience, a relatively new phenomenon. Yes, and I've been hearing this from nurses out in the field. Let's keep reading. Non-clinician leaders generally have no clue about patient care. They're business people. They treat patients like a widget in a factory. Now, Stephanie Heron, I have seen this from non-clinician leaders, and it is disgusting. We've all seen this. I've sat in those meetings, and I've been disgusted by how they see this. They do see it as widgets. Now, that's not exclusively true of non-clinician leaders. Some clinician leaders do that. There are also non-clinician leaders who are very, very compassionate and see it as a bigger connected issue. So I don't want to paint with a one-size-fits-all, but we have to be cognizant that this is about human beings. It's about taking care of each other and our patients. So by doing good, meaning the right thing, we should do well financially. Right now, that structure isn't aligned. That's why when politicians come out and they're like, you gotta do this, like, you shut your hole and go make it so that we can do that. Because right now, government's already deeply intertwined in healthcare. The illusion of being able to get them out of healthcare is just that. It's an illusion. You can't. So the question is, since they're in it, well, why don't they do something to actually make it less harmful instead of compounding problem after problem after problem and then complaining when there's a strike, right? Let's read some more comments here. Let me scroll down a lot, get to where we are. I'm an RN in a rehab unit, Colleen Cogovan. Before all hips, knees, and cabbage, now dementia and change in mental status. How can we rehab and make the patient's goals that are practical? Just what I see at my job. So this is the thing, Colleen. We have to look as a society. You know, we recently did a live cast on the Charlie Gard situation in the UK, and I had a lot of NHS clinicians message me, and this is what they say privately. They will not go on record because they don't want to create drama or lose their jobs within the organization, but they say the NHS itself is a shit show because it's very complicated and it's hard to get stuff straight and there's politics everywhere. But the frontline caregivers in NHS are absolutely dedicated, amazing human beings doing the best that they can in a system that they actually support. So the idea that the NHS is somehow, despised is not accurate. And they are all doing their best in service of the patients, and sometimes that means making very difficult decisions. So the Charlie Gard thing is very nuanced. Now the question is, in the US, can we as a system start to think about what is really evidence-based practice as applied to the unique individual there on the ground? Because we all know stories where, well, the evidence says this, but then we bent the rules a bit for this patient and they did better. How do we get better at seeing that? That's a human intuition thing to some degree, and it means spending time with our patients and being rewarded for outcomes that actually matter. And that's not going to happen overnight, but it's something we need to be working towards instead of continuing to spin the hamster wheel of Health 2.0 or to cling to the dream of going back to 1.0. Many doctors are this way. They want all their authority back. They want their fee-for-service world back. They want to be paid to do whatever it is they want to do without the accountability. And there are a lot of people like this. And that's not going to work either, guys. That's not the highest game either, right? We need to have our autonomy respected and our skill set respected, and we need to be paid for the value we generate. That's just a fact. But going back to the old days isn't an answer to that. Andrew Wilson says, I don't think there's any solution that's good for healthcare workers. I've heard the argument for the last 12 years and I haven't seen any change. It's disheartening, honestly. Andrew, there's a lot of disheartening stuff, but honestly, my feeling is there's going to come a pivot point where we are going to get better. We're already seeing some groundswell of support for it, and the political chaos in Washington is actually telling us that there is an opportunity here. So stay tuned. I think we need to keep having the discussion. It's got to be frontline caregivers who make this movement happen because nobody else really understands what's going on. And one of the pieces of feedback I got from people who've been talking to Washington leaders right now is they are appalled at how little the Washington leadership across the aisle, both sides, have no clue about what's going on in healthcare. They really don't know anything about it, and they're making these big decisions that really impact everybody. So it's terrifying. We need to have our voice heard. Let's scroll down here. And Liz Mangieri wants to raise awareness that the Congressman Steve Scalise, who was, I believe he was shot, got septic, and we need to keep an eye on keeping awareness high about sepsis. It claims many lives every day, actually, so I think that's a fair point. Jane Hansen, I've been on the clerical administrative side of healthcare for 30 years. The problems aren't new. They've just been challenging everyone for a long time. I agree, Jane. It's just been accelerating in the healthcare climate that changes. But I remember in the 90s we were having the same conversations. It was just, they were called HMOs at that point. All right, guys, I'm going to get back to my family. I'm going to leave you guys. Actually, should we go say hi to people? Let's go say hi to people. Stick with me for one last ad here, and then we'll go say hi to the Z family. Hang tight. Let me get this happening, and then we'll go say hi.
Come, Maya, say hello. Hello, everyone.
ZMomm. And she's got a ZDoggMD shirt. It's backwards because of the iPhone.
Oh, is it backwards?
Yeah, because of the iPhone, not because of what you put on.
Oh, okay. Oh, my goodness.
There's little Z-Pup. Did you have your violin lesson? Yeah. Yeah? No? What are we eating? Oh, it's P.F. Chang's.
No, she made herself a sandwich.
Oh, is that right?
Yes.
Can I see it?
Yes.
So this is my childhood kitchen here, where I ate a lot of not healthy food.
Uh-oh.
What is this? Oh, is that jelly and butter?
Yeah.
Oh no, this is made with real yogurt. Sorry, vegans. And white bread, very, very.
Whole grain white bread.
Whole grain white bread is an oxymoron, but I'll take it. So anything to tell? Come over here. Let's say hi. We're talking about this, the nurses and stuff, but I don't want to talk about that stuff just yet. Let's read a comment or two from the crowd here. ZMomm, as you know, is a psychiatrist, so if you have psychiatric questions. Mom, you put your shirt on backwards, says Angela. No, it's the way that this phone processes, see, there we go. The way the phone processes the image, it mirror images it, and I can't flip it back. So it looks like you're looking in the mirror, see?
I see.
And people think I'm driving while I'm broadcasting, but really Mrs. Dog is driving. Hi, ZMomm and Maya, says Liliana Cook.
Hi.
What do we got? The only way to change evidence-based practice, says Patricia Dorm, is for those caring for patients to document what they did and how it affected the patients so that information can be gathered. So Patricia, this is the argument for electronic health records. This was the dream, is that it would gather this information. Unfortunately, the dream of big data has yet to be realized in practice. She was a psychiatrist. Careful, she'll diagnose us, says Holly Jennings.
No, I won't.
What does ZMomm think of healthcare unions? Don't answer that.
Okay.
Because I know you have strong opinions. ZMomm was an administrator. If ZMomm was an administrator, all would be well with the world.
Oh, it's so sweet.
Daniel Livy.
That is so sweet. So sweet.
Let's see.
I'm gonna cry.
Where did Z-Dog hide his milk bottles? Didn't you say I used to drink a lot of milk?
Yes, he did.
Yeah, that's a
under
good
the
memory.
couch.
John Europa.
Yeah, under the bed. He would hide them, and he was 5 years old. Terrible, terrible, terrible. Really terrible. It was awful.
So you guys should understand this. So ZMomm is a crazy cat lady.
Oh.
She is, and the local animal control knows her by name, and she's got like 20 cats that she feeds and kittens and everything in this backyard, and so just so you know,
Yes.
all right, where the hoarding comes from. Let's see. How does Mom feel about psych patients never finding available beds? They're all sitting in the ER now.
Horrible. Just, it's heartbreaking. It's really heartbreaking. Something has to be done.
What's the solution?
The solution is that they've got to give more importance to mental health, which they're not doing. To me, it's devastating that so much focus is put on the physical health and not the mental health.
Well, speaking of mental health, Michelle Arroyo says, I knew I loved her for a reason. I'm a cat mom of 4.
Ah, how sweet. That is so sweet.
This cat thing. I don't get it. I don't get it. I love cats, says Beth Russell.
See?
Yes, go crazy cat ladies, E.B. Bub.
There we go.
It's backwards because you're used to your mirror image, so they always thought people look weird. That Deanne Haggerty, that's why iPhone flips the image, because people freak out when they see it the other way. I'm a crazy cat lady too, says Melissa Turk. Well, clearly my fans
Wonderful. That's wonderful.
Something
But
in
he's
common.
not a cat person because he hollers at me on the phone and says, they're not your cats. He doesn't want to listen to my trials and tribulations with all these wonderful cats in the backyard.
It's not a question of listening.
He doesn't
I,
care.
I call, and then I just put the phone down,
Oh.
and then I get a soliloquy about the 20 cats and the 4 kittens, and then the animal control call, and then I don't know what happened to this one, and this one disappeared, and then at the end I just say, you know, they're not your cats, they're wild cats. Like this is not your responsibility.
I know, so because I've been trying to get him to take a little kitten after they lost their cat, and he just put his foot down. Mrs. Z Dog said behind his back that she'd be happy to take a kitten. Z Pups were happy to take a kitten. There are 4 kittens in the backyard, 1 missing, and he says no. Absolutely.
How
no.
are we gonna? No. And the kitten is gonna fight with Z Rabbit.
Oh.
That's the other thing. And I like Z Rabbit. Like Z Rabbit is a tame, very affectionate animal, and easy to take care of. Clovis cats are the best cats, says Annette Simmons.
Isn't that wonderful?
That's where we are. How does she feel about Dr. Amen and SPECT scans of the brain for diagnosis? I'm not sure you know about that.
Not too
Yeah.
much.
I'm too allergic, says Kayla Schulte. Glad there are people like ZMomm that can help to take care of them.
Yeah.
And there you go.
Well, I know
Alexander
people-
Wu likes bunnies too. Wu is
I know
a
people
regular on the
who
show.
are allergic, and then that's a no-no.
Thank you, ZMomm, for taking care of the cats, says Sonia Chiapetti.
How sweet.
Take the kitten, says Marcia Phillips Gray. No! Stop telling me how to live my life,
No,
Marcia.
There's a white one with blue eyes. She's so sweet.
I can't imagine a worse scenario
But
than me having to have a cat.
Mrs. Z Dog says she'll take one.
I'd love to see Holly Reams. I'd love to see ZMomm do a show with you about grief. Z, take the kitten. Grief. Do you want to talk about? Did we not talk? We have not talked about grief.
No, we haven't.
Grief. So, how long are you supposed to grieve for?
You mean in general?
Yeah, in general.
Oh, it really depends.
Mhm.
It really depends. But I would say, come baby girl, a little Z pup is here. It depends, and the main thing is you've got to do the grief work. And a lot of people decide a few weeks after a major loss, or a month or 2, they get busy with their work or get into other relationships and they put it on the back burner. You've got to go through the pain of the grief and the loss to heal. And I would say it takes about a year, and you're really never over it, but you learn to manage it and live with it, and you know the hurt gets easier, especially when, heaven forbid, a loss of a child or a spouse after many years. You have to deal with it, and you have to deal with the pain. You have to be patient with yourself and not rush things, not make major decisions, and really not just drown yourself in busyness and other relationships, and take it a day at a time, because grief is it's just an awful thing that has to be dealt with, and one deals with it in their own way. And there's no way which is really the right way, but the way that your heart tells you to deal with it. And that's what I can say. I know people that have lost a loved one, a child, 10 years, 12 years down the road, and they're not able to even go to the graveside or look at the photographs. And I tell them that's all right. You do what's comfortable for you. But you want to make sure it's not pathological grief. If you've gone 10, 11, 12 years and you're really not
That long?
functioning, that's pathological
But
grief.
can pathological grief happen even after a year or no?
Well,
I mean, how do you sort of tease it out?
well, basically after a year or 2 years and you're still withdrawn and you go into a major depression, which is possible. So you deal with the depression. But I've known patients that have gone 10, 12 years and you know that's maybe they've not really dealt with the original grief. And then of course you have to think in terms of treating the depression. Wonderful. There are grief counselors who are excellent, grief support groups that are excellent, but each one grieves in their own way.
Deanne O'Brien Haggerty says repression is my favorite coping skill.
It's a common one. It's a common one, but then the thing of it is, then that's how sadly we get maybe a peptic ulcer or high blood pressure. So So there comes a time when the mind lets go, and you really you've got to face it, as painful as it is, and talk about it. Not necessarily to the whole world, but someone you trust, whether it's a pastor or a family person that you trust. I think talking about it on your own terms, and nobody can force anyone to do it their way. I know a lot of people recommend, well, why don't you do this, join a group, do this, but when one is ready, they will. But the first 6 weeks are horrible. It's like major surgery. But the first 6 weeks, you're dealing with a terrible blow to both the body and the mind. And then the healing begins very slowly. You find that there's a day that goes by when maybe you haven't thought of your loved one all day. Maybe you've thought of the person. And this goes for loss of a pet too. I mean, grief is grief.
No, they're talking about some pet losses, but then Kelly Adams says, I lost my oldest son to suicide. I'm still grieving, and I don't know when or if it will ever stop.
Bless your heart. What I would tell my wonderful, wonderful patients who had a terrible loss to either suicide or worse, or homicide, don't expect to ever get over it in that sense. You will always carry your child in your heart, but it gets maybe a little easier, because suicide, even deaths due to illness, when you lose a child, there's always the what if I could have, and I know colleagues that have lost children to suicide, colleagues working in the field, and it's always I could have prevented it, we're in the field, we should have known better. But it was I used to feel that way when I lost a patient to suicide. And so one of my colleagues said, what were you going to do, handcuff yourself? There was, if one is going to do it, they'll find a way. You don't want to get over your child, and you never will, and that's not what you want, but it gets a wee bit easier to let go when you realize there was nothing more you could have done or should have done, and your child, that was, he wanted out. So,
well, there's Z-Dad.
Oh, was diagnosed with
just wandering through the front. So
here,
yes. so Beth Roselle says, my mom was diagnosed with frontotemporal dementia 10 years ago. Dementia is in a category of its own related to grief, the long goodbye.
Very, very painful, very difficult. And I know family members and caregivers, they're human beings. I know many a time it's earth-shattering, and you lose patience, and you feel guilty because you're not doing what you think you should be doing, more than you should be doing. The main thing is you got to take care of yourself first, and then you can help or take care of your loved one. But it's a very painful process, and it is a long goodbye. Ronald Reagan, our president, and Nancy Reagan.
My grandmother had not dementia, but had a post-stroke.
Yeah, the what do you call the vascular dementia?
Right.
Oh my God, 7 years. That's what my mother had, 7 years, and my father was entirely devoted to her. But I know how difficult it was for him, because at times he'd say, I can't take it anymore. As much as he was so very devoted to her and devastated when she did pass away. Oh.
Curie Ransom, my kids lost their best friend to a hit-and-run DUI a year ago, and my son still struggles. Any advice for her son?
Very, very difficult.
By the way, now I have to put in a little medical legal disclaimer. This is not medical advice. This is education and entertainment. Go ahead.
Is there a phone number?
No. Because I don't have the ability to put a phone number using the phone.
But you want to put a disclaimer again?
No. That's the disclaimer.
Oh.
People know. This isn't direct medical advice.
Devastating.
Yeah.
Devastating. It's going to take a while. It was a year ago. Oh, a year ago is way too soon. Way too soon. It is devastating, but children are resilient. And there will come a time, slow and steady, when they will be able to deal with it in their own way. But it might not hurt to maybe talk to a professional dealing with grief, because this is devastating, especially for children. So that might be helpful, certainly. And you're a good mom, obviously, so that helps.
As a nurse caring for my mom with stage 4 lung cancer, it's so difficult. Grieving is on the back burner for me. Andrea Rao tired.
Yeah, you are so right, because you absolutely are bone and marrow tired with just the care. And so what you're doing is self-preservation. You're helping your mom in the most wonderful way, I don't doubt. So there's no time to even think. But the mind is a wonderful thing. Subconsciously, you'll be amazed. What is happening is that you are dealing with that situation, and so whenever the good Lord, I'm speaking religiously now, calls your mother, and it may be another 10 years, maybe, we don't know. But the thing of it is, you'll be amazed because you've already dealt with the grieving, so it's more, it's kind of, I wouldn't say easier, but it is slightly more easier because you've anticipated than a sudden loss. I hope I didn't speak through my head.
Now people are enjoying your words of wisdom. What do you think of Dr. Phil? Is he a clown or is he the real deal?
I don't know what to say. He's all right, actually. He's all right.
Dr. Phil?
Yeah, I'm not going to knock him completely, because he is a psychologist, and sometimes he does speak sense. He has oftentimes a tough luck type of thing. He's all right. I'm not going to say anything terrible about him.
You don't have to. I can say it.
No, don't.
Okay, I won't.
Yeah,
just out of respect to you, he's a clown.
Not really.
Michelle Cuthbert, my 17-year-old son lost his friend when she shot herself in the head. I don't know how to help him with his losses. Similar idea.
Devastating. Years ago, when one of my clients shot herself in front of her young children, I, in the field, an adult woman, it took me 2 years to get over that. Please have him talk to a professional. It doesn't have to be a psychiatrist, not a psychologist, someone in the field that deals with grief. It's so helpful. And if it doesn't help, always change the therapist.
Yep.
You always change the therapist. If you're uncomfortable with it, change to someone who you can have a good rapport with, and that really does help.
Guys, I'm going to let ZMomm off the hook and say goodbye to everybody. Thank you for joining us. This was about a nursing strike. It turned into a Deepak Chopra-esque psychiatry consult for free. You're welcome.
Why? Now you don't like Deepak?
No, I actually think he's entertaining.
Yeah. Oh.
No, I mean, your voice is very soothing.
Like
Deepak's. You could become a one of those new age gurus.
Oh my God.
And maybe make me some cash money.
Jim Jones.
Maybe not Jim Jones.
Is it a Jim? What's his name? Jim Jones?
Yeah, he's the guy who killed all the people.
Yeah.
Maybe that's... On that note, guys, thank you for joining us. We'll see you again tomorrow. Peace.